Thank you, Sarah. Is this,
It should be.
on? Yeah. Thank you all for having me speak today. I guess want to follow on, I think, from the message Danielle had there, to talk about a little bit of hope with the current situation. I want to make that realistic hope, but hopefully there are some things we can do at the moment to make even a little bit of difference to the lives of your and your children's lives. So obviously the holy grail and what we'd all like is a complete curative therapy, but unfortunately that's not the reality currently. We've heard a fantastic story earlier in the day about the disease-modifying treatment for Batten's disease. You saw the video of Kate's son Tom and how wonderful the treatment has been. And that's, I guess, another real goal for everybody here. But what if we can't achieve that, and we can't achieve that for most currently? What we're talking about in terms of trying to work out what we can do now is optimising the currently available care. So I guess I'm going to sort of term that reaching standard of care or optimal current care. We don't know how much benefit that this would provide in people with genetic epilepsies. It will be different for the different types of genetic epilepsies. It will be different depending on at what stage in the journey a diagnosis is reached. Experience in other neurologic disorders, such as things like Duchenne muscular dystrophy, suggests that optimising standard care can actually make a really big difference to life, to quality of life, and even mortality. We don't know how that will translate to genetic epilepsies. We won't know until we really try, but I think it's something we really need to give this a crack. So what can we achieve? Before I talk about this, I guess I'm going to present this as a lot of little clinical vignettes. I've tried to do this with a number of genetic epilepsies, so hopefully lots of you will find your child's condition represented here. And some of the things we'll touch on points that people have made already. Hopefully there won't be too much repetition, but I guess I'm going to put that in the context of what do these changes actually mean. So the first thing is something Steve touched on, and before we even get to management, we need to stress the importance of a very careful clinical assessment. And that's not just to identify the particular symptoms or problems that might need to be addressed. We obviously recognise that genetic epilepsies don't just cause epilepsy. There's many comorbidities that go along with it, things like developmental delay, autism, behavioural problems. That spectrum of things is almost universal, and then there's various other neurologic and non-neurologic symptoms to deal with. But as well as that, we've got the issue that one gene doesn't necessarily mean just one disorder. Now, Steve touched on that with SCN1A, but there's a number of other genes too where there is more than one clinical phenotype associated with the disease. So examples I've got here are KCNA2, and Renee before mentioned her child has a gain and loss of function mutation. There's also gain of function mutations and loss of function mutations. Now, each of these three different impacts on the cell produce different clinical symptoms of different severity, different seizure types, and presumably will need different treatments. We see the same thing in SCN2A, where gain of function mutations present as a neonatal or very early infant onset epilepsy, and loss of function mutations present later, for example, with infantile spasms, or even for an autism or intellectual disability without epilepsy or with later epilepsy. Again, that has treatment implications. Some medications may make that may improve seizures in one group, may make them worse in another. And if we take the genetic disorder as one condition rather than multiple conditions, we may be doing people a terrible disservice and cause significant problems rather than helping them. So it's important that that is thought of. So the seizures are not everything. We want to be able to improve more than the seizures. We want to be able to improve development, etc., and really change the long-term outcome. But the seizures are important, obviously, and they're a major cause of morbidity. Bad seizures and frequent seizures can impact on development. They impact on quality of life. So there are some conditions for which beneficial anti-seizure treatments exist. For example, KCNQ2, the gain of function variant of SCN2A mutations and SCN8A mutations, where sodium channel blocking drugs can make a significant difference. These can change conditions that often have multiple hourly seizures. Children are stuck in hospital or the intensive care unit, to turning off the seizures or significantly reducing them, at least for some of the time. Now, what that allows often is for a child and family to get out of hospital and to be able to live their lives without frequent or almost continuous seizures. Now, does that improve developmental outcomes? Well, the reality is we don't, we haven't answered that question 100%. We don't have any evidence that it makes very significant changes to developmental outcomes. Children treated very early with these treatments seem to still have significant developmental impairments, but we can't say for sure that there isn't a small benefit or an important benefit there. It remains to be quantified, but it's certainly not a miracle, and we need better treatments. At the other end of the scale is avoiding potentially harmful drugs, and you've heard from a couple of people today about the drugs that we should avoid in Dravet syndrome with SCN1A mutations. Now, why should we avoid it? What does that actually mean? Well, these drugs make seizures worse. They make them seizures more frequent, more significant, more likely to have episodes of status epilepticus. But there is now evidence that the longer you're on these medications, the more potential impact there is on development. There's also evidence for impacts on quality of life as well. And so these three significant features really are reasons why these treatments are very strongly advised against in a recent consensus statement on the management of Dravet syndrome. So as well as informing regular anti-epileptic drug treatment, a genetic diagnosis may alter the advice for treatment of episodes of status epilepticus. So you see the diagram on the left is a standard protocol for management of status epilepticus in Australia. Different places around the world will have their own versions, most of which will look very similar. And this is status epilepticus of any cause. But there are some times when these may need to be modified, and it includes the timing of treatment. So for example, if your child is very prone to status epilepticus, it may be that the generic advice we would give about administering a treatment, an emergency treatment after a seizure's gone for 5 minutes is actually not what we advise everybody. We may actually advise that a treatment's administered immediately or after a couple of minutes, because we know that in some instances the earlier you give treatment, the more likely you are to stop a seizure, and that if seizures are frequently prolonged, then the potential side effect of sedation and things is the risk-benefit of that is in favour of using the medication to stop the seizure. There may also be changes in the type of treatment. So for example, the SCN2A and 8A, things I mentioned before, you may be more likely to use a sodium channel blocker as your emergency drug. There's advice that you would give people about sick day management and vaccine management, and the obvious example here is Dravet syndrome, where febrile illness and vaccines can be triggers of seizures and status epilepticus. There isn't definitive evidence about the best approach there, but there is consensus evidence that at least in a significant proportion of patients that thinking about using antipyretics, so Panadol, Nurofen, that kind of thing, and potentially benzodiazepines with vaccine or illness may provide some benefit, and that would be something to discuss with your doctor about whether that applies to your child. On the contrary, one of the questions that often comes up is why should I actually vaccinate my child if they're at significant risk of severe complications of vaccines? And there's actually a very strong recommendation in the consensus guidelines that people don't avoid vaccinating. But there's obviously a lot of questions about what to vaccinate for, when to vaccinate for, what's the safest way to vaccinate, where should you be? Should you be at home? Should you be in hospital? What kind of additional medication should you use? And discussing with your paediatrician, neurologist, local vaccine service can be really helpful. There are many non-seizure features to genetic epilepsies, and this list is really applicable to just about any genetic epilepsy. And now when I'm talking today, I guess I'm making specific references to specific genetic disorders where there are gene-specific changes in management. But for many people with genetic epilepsies, whether you know the cause and whether there's a specific treatment, whether you know the cause and there isn't a specific treatment, or whether you don't know the cause at all, these particular symptoms are very common across the board and are things that should be addressed, and things that if we do systematically address them in recognising that people with genetic epilepsies have these, then potentially we can make a difference even if there isn't a gene-specific treatment. So as well as things across the board, there are recognising things that are gene-specific non-seizure features. So for example, many of the genetic epilepsies also have movement disorders as a feature. Many of the movement disorders are mistaken for seizures. A lot of the time things can look very similar. They're not just mistaken by parents and families, but often we get it wrong too. It's quite common to need an EEG to record the episodes to sort that out. But it's really important to do so because the treatment of these is different. If your child's being treated with anti-epileptic drugs for these movements, they're probably not going to get benefit from it, and they may actually just be incurring medication side effects. And so potentially recognising this can allow some treatments to cease. Ingrid touched before on some particular features in SYNGAP1, and one of the things she mentioned is high pain threshold. Now, that's, I guess, an interesting observation. What does that actually mean for the child? It's a quote from the paper, so it was very frequent. And just the second sentence, patients did not respond to painful events such as a fractured bone, surgical incision of a lesion, or a foreign object lodged in their foot. Now, that's a very significant things to not respond to. It's really medically important because you can obviously have a lot of complications of that may not be recognised and may cause longer-term morbidity. If you've got a fracture, it may impact on your longer-term ability to walk if that's unrecognised. Or maybe alongside a high pain threshold, a sort of similar but different feature is that you may not be able to communicate pain. You may have a normal pain threshold but not be able to communicate pain. And I think that's probably something that many of you will have experienced, that your child has irritability or is upset or acting differently, but you can't work out where that's coming from. And that can be very difficult to try and tease that out. There are some things that may not be present early in life, but may be present later for particular genes. They're important to recognise and screen for because early treatment may improve outcomes. So one good example of this, which is seen in many genes, is scoliosis. Scoliosis often worsens in adolescence as you grow, and can become a really important issue for quality of life. Children with a severe scoliosis often have a lot of pain. There's a lot of difficulties in moving and sort of caring for, dressing, using wheelchairs, walking around, that kind of thing. And there's often impact on their respiratory function. So these kind of things can have really significant impairments for quality of life, but recognising them and treating them early can avoid that. And Ingrid touched on the impact of psychosis and other mental health related things in PCDH19. And then another one that she didn't touch on, which is really important, is a later feature in adulthood in Dravet syndrome can be dysphagia or difficulties with swallowing. Now, this was seen in a reasonable proportion of children in a very long-term follow-up adults in a long-term follow-up study, and it led to very significant morbidity and sometimes even death because of things like infection from not being able to swallow and aspirating, or not being able to maintain nutrition and losing weight. And there are many things that we can do to mitigate those potential things, making sure that someone's getting adequate and appropriate caloric intake, that they're able to feed in the safest way possible, whether that's orally or through alternate means. Another really major thing, I guess, about getting a diagnosis is that it allows investigations for other causes to cease. And this is an important quality of life issue, because if these investigations are often invasive, they're often painful, many of them require a general anaesthetic, and there are potential complications that go along with that in children who are more prone to complications as a result of their neurodevelopmental disorders. So we're talking about things like blood tests, lumbar punctures, tissue biopsies, and obviously these are no longer necessary. The other thing about these is that they are very expensive tests, and we obviously want to be using our health resources in the most cost-effective way. We've got limited budgets, and we want to be able to do the best things by the people who need their health systems. So there's a lot of benefits other than the specific medical things, things like family supports, being able to access services like therapies, like the National Disability Insurance Scheme, like support groups, etc. Emma has touched on some of those, so I won't go over them now. But I guess all of these things can have potentially incremental impacts on improving the quality of life for the child, their siblings and their parents, and extended supports. And these might be things like having fewer seizures, meaning that you spend less time in hospital, meaning that you have more time to be involved in school, in family life, in therapies. There may be improvements in movement, gait, comfort and feeding that also allow people to be more involved in life. And obviously these can have potentially follow-on effects to whole family functioning, to coping and mental health, and even to things like ability of a parent to work and for financial security and things like that. So while we're not, we're talking, I guess, very much smaller benefits than cures or truly disease-modifying treatments, sometimes these do make important changes for quality of life. So how many people with genetic epilepsies would actually benefit from condition-specific changes in management? That's not completely clear. There is a recent study of a large group of children with drug-resistant epilepsy for whom a third had a genetic diagnosis, and of that 30%, a third of those, so 10% of the whole group, had a change in their anti-epileptic drug treatment, which led to an improvement in seizure control. So 1 in 3 who had a genetic diagnosis, which is actually quite a bit, and I should mention that the biggest group in that was children with Dravet Syndrome, so that's sort of not unexpected there. But they didn't quantify any of the other potential benefits, and so I guess as a whole group we don't really know that. There was a lovely paper out a few years ago about how a diagnosis in Dravet syndrome actually potentially changes your treatment. Does it impact on your management? And the answer was yes, that almost all parents reported a benefit, and physicians were asked as well, and many of them also reported that their patients benefited from a diagnosis. What was important was that those who were diagnosed at a younger age people who were diagnosed at a younger age seem to benefit than those at an older age. And so for each genetic epilepsy, we could make a table of all of the things that we would like to consider when we're in a child's management. This is not a complete list, I've definitely left some things off. But for each of these, we could make a generic recommendation for any genetic epilepsy, things like an early developmental assessment should be done and referrals made to early intervention services as appropriate. But there are also obviously condition-specific things. What I've put up here is a table for Dravet syndrome. The things in blue are the areas where the management we would advise is largely the same as for other causes, but those in yellow are where our advice would be a little bit different to other genetic epilepsies. And you can see for Dravet syndrome there are actually a number of different areas in which we would give condition-specific advice. So we could equally make a table for, such as this, for all of the genetic epilepsies. Some would be completely blue and some would have more yellow to them. So if benefits are to be achieved, how do we go about achieving the most benefit for patients? So one of the really critical factors is making a diagnosis early. As I touched on before with the Dravet Syndrome paper, the earlier the diagnosis, the more likely you were to benefit. I know many of you will have been on a very long diagnostic odyssey. Some of you are still on that. And I think recent years we've really seen a real change in how easy it is to access testing and how quickly we are able to access testing. And in fact, in the country, there's been a few examples of neonates, very young babies, receiving a diagnosis in a week or so, which is very different to not receiving the same diagnosis until you're 10 years old, obviously. And at that point, if there are management changing effects, then it's obviously much better to be able to implement them early. So a number of us, you'll see some familiar names on these papers to the side here, have been involved in trying to get evidence to support an argument for the government to pay for early genetic testing. We've all shown it's very cost effective compared with not doing genetic testing, and hopefully this will become Medicare funded in the not too distant future. Having epilepsy specialist input is really important, but this is not enough in isolation. You need a multidisciplinary team. Ideally, this would be within the one multidisciplinary clinic, but that's not a reality for many centres, but it is still very important that everybody is linked in with multidisciplinary specialists. And then the other thing is guidelines. Obviously, not every neurologist or paediatrician can be up on every single thing that they're treating because there's just too much out there. But the people who are, I guess it's sort of incumbent upon us to produce guidelines and recommendations that are available to other people so that more patients can benefit. So thank you for your time. Hopefully I've shown you that we may be able to make small changes to your and your child's quality of life currently, but really we're also all moving onwards, hopefully to novel therapies in the not too distant future. Thanks.
There you go. You collect your chocolate. Do you have any questions? And also, thank you to our speakers this afternoon. Despite my attempts to get us way over time, you guys have brought us back into line. So well done. Yes, we have a question at the back. We're going to get a microphone. There, you've already got one. Excellent. We'll start with you.
Thank you. Hi, Dr. Powell. This is not really a question. This is more of just, some comments on my experience with my daughter. So she's nearly 7 and she has SYNGAP 1. There's some new people here this year with new diagnoses, and I do hear a lot of very similar stories to my own, with misinformation and misdiagnosis from medical management. And I just want to provide some unwanted advice to the new families, and that is that, don't assume that your local neurologist is an expert in genetic epilepsy, because I did, and that was a really big mistake of mine because I feel like I wasted, several years, of anxiety and, moving in the wrong direction. I want to also let the new families know that you will probably come across neurologists who will say that they're experts in managing epilepsy, but they might not be experts. So it really is your, responsibility to join with your genetic epilepsy groups and find out who the experts are so that you can connect with them and get get the advice that you need. We had a neurologist for a couple of years who refused to seek expert advice on our behalf. I did want to say to the new families that expect to be misinformed, expect to be misdiagnosed, and be prepared, because you might get prescribed medication that exacerbates seizures and has harmful side effects.
It sounds like you had a really difficult beginning start to your odyssey.
I think so, everybody sort of seems to tell the same story as well. But my daughter was prescribed vigabatrin, and that was obviously one of the worst things that could have happened. And it was then that I realised that this was really wrong. I was also labelled as a drug addict, because every time we would go into emergency with, uncontrolled seizures, I would say, you need to give her benzodiazepines. It's the only thing that helps her. So that's something that I found out once I requested, her medical records. And also, expect not to be believed about certain things like, sleep. She can't physically sleep. It's not in her brain makeup. There was one point where my daughter Akira was having 100 drop seizures per day. And I was told that drop seizures weren't harmful at all, because they weren't tonic-clonics. So just with the whole medical management thing, I'm just sort of saying, you have to be strong, you've got to be educated, you've got to become your own expert, and you have to learn to say no if you don't agree with a treatment. And you really do need to find out what drugs work for a specific disorder. Because that'll really help.
Let me, if I can, interrupt you there, because I think you've, given people a lot of information about your journey, and I think it's, first of all, my heart goes out to you, because it just sounds like it was really, really tough.
It was horrendous.
And it sounds horrendous.
It really was.
It sounds horrendous, and I'm really glad you're here. And I would just love to ask you, Katherine, because it is hard, particularly at the beginning, if people are trying to wind their way through the system and get to the right people, and not have such a really harrowing experience. What would your advice be for new parents?
Sure. Well, first of all, I'm so sorry that was your experience, and I know that you're not alone in having such tough experiences here, and they are awful, and it's unfortunately all too common, and I guess it really is quite humbling for us to know we've got such a long way to go to really help your children. I think we're all very determined to make gains on that front. I think we are, but it's step by step, and there's many things that we, as I guess people who do this all the time, don't know. And so it's very difficult, I guess, then to expect that people who are not experts in the area know that. Now, the issue of people who are not experts considering themselves experts is, I guess, a different matter. But from my point of view, I think we need to keep learning about things, but we also need to be able to disseminate that information. And Emma touched on a lot of that and the ways to do that, and we are all involved in different aspects of providing information, whether it's on websites or booklets, etc., to families and to clinicians.
Or events like this.
Absolutely.
Really, I hope and trust that everybody, that is one of the things we really did, was to really find some experts here who can
that's right.
get us on the right path.
Yeah, I think I guess, finding support groups, finding who the other people with your child's condition have found helpful, finding epilepsy genetics clinics in your country, asking your neurologist who the experts are. You know, sometimes people are a bit threatened by the idea of a second opinion. I don't think it should be seen that way. I would, you know, as a neurologist, deal with neuromuscular disorders and various things, and they're not my area of expertise. You can't be across everything, and it's so valuable to have somebody who is across that, give that advice there too. So I think we all recognise that we have significant limitations, and we're all trying our best, but it sounds like you've done a fantastic job for your daughter.
And as we move on to the next speaker, I just want to say thank you. Thanks for raising this.
Thank
We
you.
accept everything. We really do. Do we have other anybody else who has a question? Jenny, I'll come to you in a minute, but I see some at the back. Yes?
Hi, Catherine. I'm new to this game. My daughter's been diagnosed with Dravet or Dravet Syndrome, MAE.
Yep.
You brought up the topic of vaccinations, when to vaccinate, what to vaccinate against.
Mm-hmm.
Where do I go to find some more information on that? Because it's such a taboo subject. No one's giving me a direct answer.
Sure.
You know, there has been thought of that's what triggered her epilepsy to start with at her 18-month-old vaccinations. I haven't vaccinated her since.
Yep.
But now we're coming up to winter season, you know, with an array of potentially dangerous.
Yeah. So first question, are you in Melbourne?
No, I'm from Adelaide.
From Adelaide.
So we do have running water and bitumised roads, but we're still a country town.
Good to hear.
Adelaide.
Why do you ask?
We know, can I just say one thing? We know that there has to be something really amazing about Adelaide because we see the people that Adelaide has brought here.
There's a reason why we're all here.
There has to be something awesome about Adelaide because you all are amazing.
Yeah. So I think there's two avenues at which to come from that to get the best information. One is there will be some questions that a neurologist can answer, and there will be some questions that a paediatrician who's expert in vaccinations could answer. Now, I asked if you're in Melbourne because at the Royal Children's Hospital we have a fantastic immunisation centre. They run a clinic where you can come to discuss your child's circumstances, what the specific issues are, and make a plan for if and when your child should be vaccinated and how best to do that safely.
Do they have a hotline? Or?
I don't know about a hotline, but if you go to the Royal Children's Hospital website, which is www.rch.org.au, and search immunisation centre, or even just immunisation, you should find it. They have some terrific paediatricians and immunisation nurses, and I refer a lot of the children I see there, and they're fantastic. I don't know if a similar service.
I've definitely used them. The RCH, we moved over from New York, we used the service, and I know for our daughter, I wouldn't presume what the particular genetic mutation you have is, but I know I was terrified. I knew we had to do it, but I was really scared. And what we did was we would prophylactically, we would in advance give like Panadol or Nurofen, and we made our way through it. So I'm not giving you medical advice. I am not a doctor, but I would say talk to them. They were so good at working with us as families, and it's okay to be nervous.
And I would be able to liaise over the phone via that way, or
I don't actually know, and I also don't know whether a similar service exists in Adelaide. But I guess the first step would be to contact them and ask, if there is a local service, or whether they could see you or provide advice.
Thanks for the direction.
It's okay.
Excellent. We've probably got time for one more, and then I want to cut us off so we can have afternoon tea and come back for two more things. Okay? Any more? Jenny's waving me off. Okay. But no, during the break. Okay.